The topic for this presentation is Bruton's agammaglobulinemia, and this is a pediatric immunodeficiency. Now, one thing is important to remember is that pediatric immunodeficiency disorders, there's quite a few of them. There's probably as many as 15 that are tested on the licensing exams, and this one in particular involves the B cells. And before I get into this, I'd like to draw a diagram of all the different types of cells, and that will kind of help you understand a little bit better about what's going on. So first, let's just start with blood, and we're going to draw a diagram that breaks down blood into different components. So the first part is the cells, and the next part over here is the plasma. Now, the plasma is approximately about 55% of the total blood, and plasma is broken down into serum and clotting factors. But this presentation is really about the cells in one particular cell. So let's just keep going with cells. Cells, well, there's three basic types of cells in the blood. There's red blood cells, RBCs, white blood cells, WBCs, and platelets. What we're going to concentrate on is the white blood cells. Now, the red blood cells are approximately 45%. The white blood cell and platelets together make up sometimes less than 1%. But don't let that number fool you. They're extremely important. Okay, now white blood cells, that is what we're really talking about. There's two types, two categories. There's granular and agranular. And the granular ones, you probably have heard of these. There's basophils, eosinophils, and neutrophils. We've got agranular. You've got monocytes and lymphocytes. And then finally, lymphocytes. Finally, just when you thought it wouldn't end, you've got lymphocytes breaking down into two types, B and T. Why did I draw all this out? Well, because it's important for you to understand that this presentation is about this, B cells. Why are B cells important? Their principal function is to make antibodies. And antibodies, also known as immunoglobulins, are responsible to help the body fight infection. That is what this is all about. In the middle, as you can see, you've got X, this big X. And this big X is referring to the fact that it's X-linked. It's found on the X chromosome. It only happens in male infants. Why does it happen? Well, it happens because there's a mutation in the gene on the X chromosome. So this BTK is the gene that has a mutation in it, and as a result, you are not able to produce these B cells, because these B cells are produced with the help of this BTK gene. The BTK is essential for the B cells to develop. Without the BTK gene, you cannot get B cells, and as a result, you don't get antibodies. So that's what this is all about. Very important. This happens because of a mutation in this gene. Okay. Yeah, it's a cute little diagram. There's a lot of B's here. I think, that kind of helps. And it also helps to know that B is in Bruton. So that's what that is all about. All right, now let's get into the disease. Before I get into the symptoms and all that, I just want some key points. Male infants. And you're going to see this term on licensing exam, encapsulated bacteria, or the types of infections they get. Why? Because those antibodies that you don't have, because you don't have the B cells, are responsible for fighting these encapsulated. Now, if you don't have them, these encapsulated bacteria will cause infections, and there's two in particular that really, really stand out. The Streptococcus pneumoniae, and then the other one is very, very commonly tested, Haemophilus influenza. Okay, remember those. Now we can get into the clinical history and all that. Okay. All right. So what is the clinical history? How does a patient present? Well, the key is you have a small child, maybe anywhere from, well, a few months old, perhaps. Recurrent infections is the theme. And you don't really even have to memorize that. It's just a common sense, because they simply don't have the antibodies. Recurrent infections, chronic infections, or atypical infections. The child just keeps getting infections because the B cells are no longer there. Remember, there's that, well, it's right here. The BTK gene that's responsible for B cell development has a mutation in it. So the B cells don't produce, and as a result, we don't have any antibodies. Now, when you say infections, what type of infections are we talking about? Well, there's quite a few. Respiratory infections, there's diarrhea, sinusitis. You can get, you can also get bronchiectasis, and but it's mostly respiratory. But you can also have other types of infections, and the child will also have a failure to thrive because there's malabsorption involved as well. What kind of things do you want to check on a physical exam? Well, certain things, because of the failure to thrive that can be present, you want to check the height and weight. And then, of course, you're going to do the lung exam, but there's certain things you want to pick up on. You want to pick up on the tonsils. And the reason is because tonsils are going to be very small or even absent in Bruton's disease. And you might even see that the child is malnourished and might be anemic, and you might be able to see the pallor associated with the anemia. So these are some of the basic things you want to check on a physical exam. Now we get into the diagnostic testing. Well, you actually can detect in laboratory tests the B cells, and these will essentially be absent. The next thing you can check is the antibodies that B cells normally produce. You have IgG, IgM, IgA, and they will be low. Okay? Now, you can also do other tests to identify the organisms. You can do a sputum culture, and that will be positive for the bacteria that is causing the infections. Encapsulated bacteria like strep and Haemophilus. You also can do a CBC, because in Bruton's a child may be anemic, and they might have low platelet counts as well. Well, this is basically how you diagnose it. Now, how do you treat it? Well, the treatment is actually very, very straightforward. Because they're very low in their immunoglobulin levels, you have to give immunoglobulin in IV form, and the treatment is once a month, lifelong, because they just simply can't produce them. The levels will be very, very low, and as a result, they'll just keep getting infections. They just don't have the immunoglobulins necessary to fight the infections. So you have to give these immunoglobulins once a month, forever. And then the second part of the treatment is that you have to give the child antibiotics, also prophylactically, meaning they don't even have an infection, but they're on antibiotics. And that's basically the bread and butter of Bruton's. So you have a 9-month-old baby boy, is evaluated because of repeated episodes of pneumococcal pneumonia. Serum studies demonstrate very low levels of IgM, IgG, IgA. This patient's condition is thought to be related to a deficiency of which of the following proteins? Well, you remember right here, the BTK gene is where the mutation is. And do you remember what BTK stands for? BTK stands for Bruton tyrosine kinase. So The patient has X-linked Bruton's agammaglobulinemia, which is due to a deficiency in tyrosine kinase, leading to a B-cell maturation arrest. Mutation of an X-linked gene coding for tyrosine kinase is the underlying molecular mechanism leading to X-linked agammaglobulinemia of Bruton, a syndrome characterized by the inability of pre-B cell precursors to mature into B lymphocytes. Humoral immune deficiency thus manifests.